grateful to be part of that with you, part of that journey with you. I'm going to be brief because we have extraordinary speakers today, and it's going to be much more desirable to listen to them. But before I say a few remarks, I have to do a shameless plug for our Halloween ball. All of you got the invitations coming up October 24th. It's a really fun night at Oweka Castle. And what we do as an organization is we honor children because we believe in raising stewards of social justice up on Long Island and really recognizing them. So we're honoring 3 incredible girls this year, some of which have overcome incredible trauma and are giving back to their communities, and all whom are extraordinary children involved in civic life and making a difference on Long Island. So if you can join us, I promise it'll be fun. Costumes are optional, but they're really fun. It's really fun to dress up. So thank you. So we, the collective in this room, have been really working tirelessly to build a health equity movement on Long Island. And so why have we been doing that? It's so important at this moment in time for so many different reasons, including the quick and very significant demographic shifts that have occurred in our region since 2014. The fact that diversity has increased, but segregation has persisted and goes back to our roots as a region. In fact, our legacy as a region, as you know, was built on foundations of segregation, beginning with 11 homes that excluded Black families from home ownership through restrictive covenants. That intentionality that framed America's first suburb was not even 100 years ago. And so we continue to have tremendous work to do to dismantle the fact that we live in a region where your zip code is largely determinative of your health outcomes, your social mobility outcomes, your educational attainment, and so much more. If a community's potential on Long Island is limited, yours and mine is too. If people are unable to access basic health care because of their immigration status, their access to services, transportation, or cost, if people are unable to access needed mental health treatment, who suffers? Individuals suffer and family suffers, yes, but so do schools and so do entire communities. And that is why we all came together as nonprofits to really work intentionally to vision out and to plan for new systems and a new way of meeting our needs here on Long Island. I don't know about you, but I am so exhausted from the vision that is, being handed to us every day on TV and on the radio, the constant assault on people's basic needs, their rights, the manipulation of our sense of who we are as a collective humanity, and the notion that every single person doesn't have value. So we as the health and human services sector in this room, we know better, and we are working together to do better, and I'm so proud of all of us for that. So the genesis of today really comes from the need to be able to build a vision beyond the framework of our alliance. We've talked endlessly about a business model for our sector, about how we will engage with healthcare systems and MCOs, and how to prioritize what we know about our community's needs. And yet it is hard to plan when you haven't seen successful models. It's hard to vision when you haven't seen a vision. It's hard to build without being inspired by great work that's being done elsewhere to achieve similar goals. And so that's what brought us here today. We have 2 fantastic speakers that you will hear from shortly. Laura Gustin from United Way of Rochester, who will speak about how health and human service agencies in her region are driving the work behind systems change and collective impact. And Ngozi from Brooklyn Perinatal Network, who will talk about how they are using a national system delivery model and making it work for their community's needs. It's very exciting. But before we welcome the speakers, I really want to welcome Emily Rogan, who you know is a fabulous member of our team and who has really been working so hard to drive the efforts with this alliance to make some remarks. Thank you.
Okay, so this is really not, first of all, hi everybody. Thank you for being here and for being tolerant and patient of our endless emails and reminders. And John, I don't see the, excuse me. Where's the, sorry.
One thing, we're really great about a lot of things, but we tend to have technical difficulties.
No, and this happened last time. Anybody that was at the meeting last time in this room, I had the same issue. So anyway, I don't know. So first of all, I want to just say thank you to everybody. everyone's input and your enthusiasm around the work that we're doing has been really inspiring for us and for our team. So we had, and this is really not going to be a work session for us, but I wanted to just go over really quickly what happened. We had our initial work groups convene through conference calls, and we came up with some draft goals. So for those of you who maybe aren't up to speed on this, we have broken out into 3 work groups based on the survey results that we did a few months ago, based on what you all prioritized that this group needs to be focused on. So, and I will add, if you have not yet volunteered to join a work group, John has a sign-up sheet out front, and we'd love you to pick one. It is really not too late. We've only had 1 introductory convening so far. So, and I'm not going to read them all to you. We will send these out to you by email after the meeting. But I will say that all of the work group teams have chimed in, and we've gotten overall pretty positive responses to what these groups are working on. And what I want to do is sort of segue that into our wonderful guest speakers today, because a lot of you have asked me, offline separately, like, what is this all going to look like? What are we working towards? And so these work groups are the next step to get us to talking about both the systems, service delivery model, and also systems change in our region. So it's a perfect segue to introduce you guys to our first speakers. So we have a couple of our work group chairs in the room. If you're a work group chair, can you just put your hand up? A lot of them couldn't make it today. So Michelle's here from the Advocacy and Policy work group, right? Did you want to add anything?
Not really.
Okay.
We'd love to have people join us, obviously. The more the merrier, and as many hands make light work. And just to get your insight into what you feel is important. I think it's very important to hear everybody's voices.
So to that point also, our next work group meeting is going to be here in this room. It's going to be in real life, not by conference call, on October 17th. It's from 10 to 12, John. And what my vision for all of us to do is, I'm hoping that what we'll do is we'll have each of the 3 work groups break out into little groups here and then come together and just make sure, because there's been some concerns that there will be overlap in the work that each of the teams are doing. So I think it's going to be a really exciting meeting. So again, if you haven't yet joined one, it's not too late, and we really love your input. So to that, I'm going to, you all have in front of you, I hope, the bios of our esteemed speakers, so I'm not going to spend a lot of time reading them to you, but I do want to just say that we spent a lot of time doing research and looking for relatable projects and innovations that were happening, and a lot of them were happening in other parts of the country. So we were really, really thrilled to find out what the folks in Rochester have been doing and what the folks in Brooklyn are doing, because it's right here in our state. So they're working under the same governance systems that we all are. They're working under the same concepts from DSRIP and are looking beyond DSRIP to value-based payment. So we're all kind of doing the same thing, differently, obviously, more specific to our region. So Ngozi, and also I need to introduce Denise West, both from the Brooklyn Perinatal Network. They have adopted, or are starting to adopt, the Pathways Hub model. And you may have even heard me mention that once or twice in some of our past meetings. So we asked them to come speak a little bit about the genesis of their work and where they are and what they're doing. And then after they're finished, Laura Gustin from United Way Rochester is going to talk to us about this kind of amazing braided systems and coming together of all different health and human service agencies, funders, the whole shebang. It's kind of amazing. So I really hope that by the end of today, you will all walk away with a much more solid concept of what we've been talking about and what we're moving towards here on Long Island. And we will do Q&A after both presentations are done. Okay, so any questions? No, we're all good? Everybody's got coffee, water, cookies? Okay, great. So with that, I'm going to introduce the folks from the Brooklyn Perinatal Network. And I'm just going to find your presentation. John, do we have a clicky thing?
Yes.
Good afternoon, everybody, while we work on technology, because we're not good at technology today.
Good afternoon.
Good afternoon, everyone.
Good afternoon.
Oh.
So good afternoon again. I'm Ngozi, Brooklyn Perinatal Network, the executive director. I don't sustain leadership and staff over a period, and I think that BPN is one of the few that we have been fortunate to have both of us bring the organization through all the ups and downs of the life cycles that affect the nonprofit world. What I want to do is give you an overview of BPN and then get to why the pathway model was selected and is considered a choice for the work. We do everything collectively. From the inception of BPN, we took the decision that there's no one organization or government that can meet the needs of the under-resourced and underserved communities, the vulnerable population. And therefore, we have to collaborate, we have to partner, we have to do things together. And I would say about 99.9% of BPN projects are collaborative projects. We have taken on the responsibility to reach out and bring in to pioneer collaborative efforts with both community-based organizations and our service delivery system providers, our hospitals and health centers and things like that. And in reaching out for collaboration, we have a footprint that is larger than the size of the agency because we don't do it alone. And so I'm happy to share with you because it seems like you have the same model for sustainability. And so 30 years ago, when we came together with the blessings of and the mandate of the Department of Health, it was to address infant mortality and why it's high. And the first thing we recognize is that infant mortality and the rate we were seeing is a condition of something else. It's a condition of the impoverishment of families and communities. But we understand that it's easier to work with a pregnant woman as an index client and then get to the family and then get to community, but they were not separate and apart from each other. And one of the things we recognized very early is that service fragmentation and lack of coordination was a major service delivery system determinant that affected outcomes in the community. For instance, a client may spend a lot of its time running from one agency to the next just to survive, get this here and get that there, and then no time to follow up on the things that are health related to really progress with health outcomes. And so BPN had several ways of going about trying to reduce infant mortality. One of them was work with the system providers to address the issue of fragmentation, work with policymakers to have them to understand what's going on in their community, what the gaps, the need resources are, and what policies are either impacting or helping the delivery of resources and helping people access. Another strategy was working directly with community-based organizations to inform community residents and engage them in the work that we felt needed to be done. And in doing that, the collective approach was necessary. We wrote grants, and every grant we wrote had partners in it, and our practice has been about 50% of the grant money went out to partners to deliver whatever it is we agreed that we would do, and the rest would be for administration and the coalition building and everything like that. and we also directly delivered services. So that was our approach. And so the collective work, when we started collective work, we just started. You ran out there and you got the work done. We had no model. We were doing based on what grants wrote and what the grantees wanted, and based on what we know the community needs. And after a while, and you spend so many years doing this work, and you're seeing that the dial in the community isn't shifting much, you begin to ask yourself questions like, are we working effectively? And we know that we didn't have the resources to address the whole problem. But we wanted to make sure that what we did was as effective as it could be. And we partnered with the health department, the city health department, and we relied on them to try to help us identify approaches. And we partnered with them on grants, and sometimes we lost out because the grant was taken from us and the health department ran with it, and we were kicked out the door because there was a better partner that the health department could work with. Nevertheless, we sustained our partnership with community-based. When I say we, I'm talking about the collective partners. But we continue to commit ourselves to community collaboration, and sometimes we fought with the health department when they did things that we felt were not appropriate, and then we collaborated with them when we realized it was to the benefit of the community. We didn't hold any grudges because the community was our goal. So there are a couple of projects. I noticed one of your work group said that on technology, and so in addition to the hub, I want to talk about a project that we're doing that relates to exactly that data and the technology. Over the 30 years, we've pioneered and led and advocated for and brought resources in for several initiatives, two of which are sustained within the health department right now. And when I told you about take the money and run and do something else, two of those initiatives are in that category. But they didn't get far because we kind of advocated and pulled back and got engaged in the project in some way. So the Healthy Start National, Healthy Start is it? Healthy Start HORSA initiative is something that BPN was one of the prime initiators for working with MHRA, Medical Health Research at that time, and the health department to bring monies in. And for 15 years, we brought those money in, 3 cycles, and then we allowed the health department to take the lead, and that project is sustained now, but not as it started. It's sustained with a model and an approach the Department of Health felt was more beneficial and effective, and that's okay. When the Healthy Start Bedford leadership went to the health department, we continued to work with the consortium piece for a while. And then we got another initiative funded by the city council, because we said to the city council, the city needs to put some money into community work, and the Infant Mortality Reduction Initiative was born. It was a citywide initiative that funded between 25 to 40 organizations to fill gaps in their service delivery system to address maternal child health clients whom they may come across. Some were housing organizations, some were welfare organizations, some may have been youth organizations, some may have been economic development, but they all saw pregnant clients. And the clients who were coming for what they could offer, but they were lost to anything maternal child health. So we got those organizations to incorporate maternal child health into their service delivery by getting the city grants. And so that's an initiative that was sustained for about 15 years before it was baselined in the budget, and the health department has that resource now and runs a maternal infant health outcome project, and we are participating with them. But we also maintained, with advocating to our council, a smaller grant for a network in BPN to continue to do some infant mortality work around a perinatal health information technology program that we see as important to service coordination, and that's the data piece. And so the next initiative was that we got involved with and pioneer was the Pathways Hub. Now, when we started the Perinatal Health Information Technology Project, it was a recommendation went to the Medicaid redesign team. I was on the council, and a number of advocates on the team felt that that recommendation to build technology capacity among community-based organizations. The medical community had their technical capacity, but CBOs did not. And so they funded an initiative at the Department of Health based on that recommendation to develop a perinatal health information technology project that was upstate, downstate. There were 3 partners upstate, 3 perinatal networks. Upstate got the grant, and downstate we got the grant, and I think that it was because we had initiated it. So the perinatal health information technology is something I would recommend, that if you're looking at a technology product, you may want to look at something that the state has already invested in, and the state is considering at this point asking all its MIT programs to use that for their reporting and data. What it does, what we did with the PHITs, we used first CDC funds and then this Perinatal Health Information Technology Fund to build a referral system around among community-based organizations. And with the MRT funds, it linked to medical providers and sent information through the RIO so that medical providers can get their client information at the point of service. For instance, a client might be in an emergency room, and a medical provider might pick up that client, and when they pick up the client, the information on the client's social health will automatically populate the record. So they will have information they didn't have before. We don't know that there's any other system like that in the state. We think it's the first, and the state has supported it since 2014. And we are in what we call an extension stage now. So after we got that project, and we used that project for coordinating referrals and making sure that we had an easier way to refer and track clients and then know that the client entered into a service. We recognized that that alone was not enough to really coordinate services, and we've been looking for an evidence-supported model, and we came across the Pathways Hub. And when we came across the Pathways Hub, we looked at it for about 3 or 4 years. We wrote proposals with local hospitals, and we weren't funded. And then in 2015, last year was what, 16? 2016, I reached out to the developer. I was at a conference called Communities Joined in Action, which I would encourage you to participate in. It's both a network and they hold annual conferences. And at that meeting, I reached out to the co-developer, the Pathway Hub, and I said, look, we need some help. We'd like to use this Pathway Hub now that value-based payments are coming, and all our partners needs to have evidence-based approaches, and you need to work with risk-based approaches, and you need to measure everything, things like that. And he agreed to work with us. And then we had a local champion in Health Management Associate, Heidi Arthur, who agreed to give us some pro bono time. And she was already working with us on the CTHE and had bought into the idea we had. The Pathways Hub could not be funded under the CTHE work because it addressed maternal and child health, and none of the district projects addressed maternal and child health. So I reached out to Jason Helgeson, and I said, look, you're asking for Tier 1 CBOs to be engaged meaningfully and address the social determinants of health, and here is a program model that we feel could both organize Tier 1 CBOs into a network with standardized care, a way to deliver care, measure, and serve, use community health workers, and be qualified to get the VBP contracts with plans. We'd also become aware that plans were unwilling or afraid, both afraid and unwilling to work with small CBOs who didn't have a lot of infrastructure, because they did not feel that they could trust that those organizations could deliver quality work could be sustained, would be here today and gone tomorrow and things like that. And we felt the Pathways Hub was a way to cross that bridge and help the CD out. And so I'm going to have Denise West talk about the Pathways Hub. And I'm going to have her walk through a hypothetical client so you can really see the meaning and the value it adds. And then I'll come back and I'll talk about why the hub is important to help organize community-based organizations who are tier 1. They're not billing Medicaid, they're small, they don't have a lot of infrastructure, very much like BPN. You've been around forever, you've got boots on the ground, you know how to reach the client, you can do the work better than any other organization, but you still can't be sustained. You're going from grant to grant, and when a grant is pulled, you're left with the client wondering how can we not disappoint this client, and trying to do work. So, so the Pathways Hub, we feel, is a must-have for us, I would say, if our organizations are going to be sustained. Our valuable, very credible, community-trusted organization. Nothing in the managed care plan and the DSRIP mandates that are given compels them to help community-based organizations. It's just saying they must work with one. And the challenge is you must work with one, but if you don't feel confident to work with one, then the way you will work with them will be minuscule and our communities will not benefit. And so we felt that the Pathways Hub, which gives service pathways that are recognized nationally and have a component to also organize the community-based organizations to work together, is a way for us to go. Denise?
Okay, so Ngozi talked some about the Pathways Hub, and you're going to talk about the pilot?
Yes.
Okay, so we're going to skip around this.
Well, I wanted you to, I said we reached out to Jason, but before I say about the pilot, I wanted you to just understand, you know, when we reached out to Jason, why it interested him to invite us to submit a proposal.
Well, one was because it was going to use community-based organizations that have the track record of identifying and reaching women that are at risk. The other is that it utilizes a community health worker model, and you know that when we talk about district, everybody's a community health worker or a peer educator at this point in time. So those were two of the key pieces that Jason was interested. But then it has a hub piece, which Ngozi will talk about more, and then pathways. So there is not infrastructure, there's not, CBO do not necessarily have a strong administrative, technical assistance, financial infrastructure. This is two pieces. The hub is that infrastructure, and then you have the pathways, which is the service model. I just said that. And the other piece that we are hoping to do is to complement some of the new initiatives that the state has as the 1,000 days for Medicaid in that population there. And the other component is that it has what you can do, or what you can call braided or blended funding. So the state is clearly interested in that. They don't have to pay for everything all the time. Golly gee whittakers, where was this program? So for a client will receive, each client receives a comprehensive risk. So you may come in because I'm pregnant and I'm thinking I need to go to prenatal care, but you're going to get behavioral risk, which is key and important. You're going to get health, you're going to get social risk. It's comprehensive. And after each assessment, all risks identified are now going to be going through a certain pathway. So you have a client. So you have, in Brownsville, we have Moesha. Moesha has one case manager, so you have one community health worker that can work with all the families, and it doesn't necessarily mean that all families get the same types of services. So we're going to just say Moesha, who is pregnant at this point in time, she comes into a community health worker, and I need prenatal care in Brooklyn, at least in most of the cities. People have issues with housing. Housing is at an all-time, not any people are migrating or going underground and we don't know where they are. We have people that come in for, that are pregnant. You're interested in giving them health education and breastfeeding, and they're saying, well, I'm not going to have diapers for my child. I'm not going to have a crib or the pack and play to put them in. I may eventually, as a community health worker, find out that she's being abused, domestic violence. So all of those different areas, when she comes in, based on the assessment that I have, that I do, so I'm the community health worker, I identify all those different risks that she has. They all move into an individual pathway. So you have a housing pathway. You have, still for this one client, Alicia, you have a social service pathway. I'm really suffering from depression because getting beat up every day. And we know that as pregnancy, domestic violence increases when women are pregnant. I'm going to need that. I may need child supportive services. Each of those become a different pathway. So you're making each of those individual referrals and you're checking off, have you made it or not? And so you may ask yourself, particularly for housing, knowing that we don't have any housing, well, did you put her into a shelter? Did you get her into housing? You may or may not have gone through to the final step, but whatever you do at the level that you do it, you can also get reimbursed. And so one of the key things is that I could work with her domestic violence. I can work with just her MCH, her prenatal piece, because now I got her into the FQHC. I can work with her needing some other social support services that she's going to need, the diapers that she's going to need, the pack and play. I can get her into breastfeeding. I can get her into seeing a counselor for possible depression or something. And she may live with her mom, who also, now that I have Moesha and you're pregnant, this is an extra house, an extra mouth that I gotta feed, or you're eating more out of a house and a home. So the mom may be in a pathway for food. How can we link her up to food programs such as SNAP, Medicaid, or food stamps? Each of those different risks are not lumped into one. They are an individual pathway that allows the person to, we're sticking with this one, that allows wherever you reach to get reimbursed under that particular pathway. And you remember I talked about the different braided and the funding. Don't let me come up here and break up your piece, because I'll be on the pathway of, ooh, you can't come back no more. Based on whatever that pathway is and whatever accomplishments you make, the community health worker will get reimbursed for that. So that money goes back into the hub as the administrative piece and then issued right back out. I believe it's about 70% goes right back out into the services. So don't think of the hub as, and I hope I don't offend anybody, that you know when you do a proposal and you do it with the medical institution, the administrative cost is really high. And you're like, so we wrote the grant, we just needed to use them because we had the research piece, but we're not getting any money from this. This is not this model. This model is a model that comes right back out into the community. And Ngozi, I don't know if you remember how much, but it's like an 80 to 20% ratio that the hub is putting the money in for training, the infrastructure, and paying back out. So why do we like this model and why is it helpful for community health workers is because you get to, number one, for the individual community health worker that's identifying and finding the woman, she's going to get some return on investment, just being glad that and being able to track that I made some accomplishments. Our community health workers don't necessarily know that now. So I may not have gotten to where I wanted to go under the child welfare pathway, but we met all of our risk factors and our deliverables for the maternal child health. We met them all for the social services. She is going and we're following up with the behavioral health piece. So I think any question, oh, we're going to do questions later.
Yeah.
And then we also are including in the chart, so this is a pathway, we are also including how and this person gets reimbursed, and what rate of funding. I'm good. See, so you have one coordinator, and she can see the whole family. Different, not necessarily the same risk. And these are the basic, as it stands now, these are the 20 different pathways that one can have. We hope that one person may not need them all, but when we talk about social determinants of health and we talk about how to really improve health, and most of it is related to social determinants of health, these are most of them. Ngozi, how much time do we have? I saw the whisper.
Yeah, it wasn't the whisper.
It wasn't about our time.
About time, no.
But soon, you have
Okay.
a couple more minutes.
This is
So
very-
I just wanted to walk
this
you all
is
through
great.
that.
This is a great, this is very helpful. Thank you.
So, so a key thing about the Pathways Hub is that it's a care coordination model. It's a standardized model so that all the organizations who agree to work in the Pathway Hub network will have some standard ways of doing it that are nationally certified. This model has been approved by the AHRQ. It's been tested by the AHRQ. Some pilots have been funded and they certified it as evidence-based. And they promote it as a very important and vital model when you're working with collaborative community, collaborative organizations. So it's not like one agency is doing all of that. Denise mentioned that maybe her organization can get the client that, and that. Maybe her organization can get the client job and housing. So that there is a referral and a follow-up and a standard way of measuring and tracking that to make sure that the needs not only of the client, but of the family. It's a family-focused model that uses the client as the index way to get to the needs of the family, because no client problems is independent. It's all interdependent on what the resources and the situation of the family is, except in those cases where she's kicked out of the family. And if she's kicked out of the family, then she needs a family support network. And that's one of the things that the community health worker will make sure is a risk factor. So it's a care coordination model, and very often the care coordinator in the Pathways Hub is coordinated with other entities that she or he's using, the family's using, so that there aren't multiple invasions of privacy of the client as happens now. It comes together. So agreements to work together and to stick with this collaboration and partnering and using each other's resources effectively is an essential part of this. Now it's all worked out. We don't have to create anything. We just have to take the model and tailor it to our environment. So when I spoke to Jason, I was at a boot camp, VBP boot camp right here in Long Island. Was it in Long Island? Yes, right here in Long Island. And he was talking about risk-based model and CBOs and so on. After the presentation, I went to him and I said, Jason, I have a model, something I sent to you a couple of years ago, and I didn't get any particular interest in it. But I'm bringing this model back to you again to say that here is a model that we're interested in Brooklyn to address mental health that can help do the things that you want CBOs to do working with boot camp. And he listened to me, he connected me to his staff right away and said, call and set up an appointment for us to talk. And we did that, we talked, we had a couple of discussions, and he said, send us a proposal that outlines how you see this Pathways Hub working in Brooklyn to address maternal health, make sure that it coordinates with health homes, because that's our standard payment model. Make sure that district providers at the table, and make sure that you work with managed care plans, because they are the funders and the payers of the system. And then Jason left, and before he left, he connected us with his team for them to continue to work with us. And so right now we do not have a pilot, but we've been in conversations with the team at the Office of Medicaid. We have outreach to managed care plans and interested them to work with us. We've outreach to community providers, family health center to work with us, and we now have a critical mass of support. And currently, the Office of Medicaid is reaching out one-on-one to the managed care plans to make sure they're not just hearing us say they're interested. They're talking to them about, are you really interested, because this is a project that you're going to have some responsibility for investing some funds, for paying for services. We've asked them to fund the first year of the project fully, so that we can have a planning grant without waiting to have all these agreements about who will pay for what, an organizing period, and then the outer years will have contributions that will be identified in our application by the managed care plans, or maybe a health center if they want to be a payer because they have a contract with a managed care plan to get something done, but they want to hire the hub organization to get some of that work done. And so currently we are waiting, expecting to complete and put in a proposal by this fall, so that they can begin to find the money. Now, when we spoke with them, they said it's the first time that a community-based organization has reached up to the state and say, we want to do a pilot of this kind, and we're happy that you did it. And we put the funding together from the VBP, 1,000-day Medicaid, full cost of care, managed care for all. We don't know exactly what will come from where, but we'll need to pull money for this. And they told us, in feedback on a framework that we gave them, they told us that they want us to do certain things. And at the end of this pilot, they would like to, well, not at the end, but as one of the outcomes of the pilot, and it will need to happen during the course, they want to be able to revise the maternity bundle payment, because none of the managed care plans are grabbing at it. They're kind of like, you know, this thing don't make sense. So the managed care plans at the table, and the state would be the table. They would work through together what the maternity bundle should look like. Who pays for what? How the CBOs get paid? Does the money flow directly from the state, or it comes through the managed care plan? Is it an enhanced payment? What does that enhanced payment look like? They want us to work with 1,000 days Medicaid, connected with the perinatal period. The maternity bundle has some gaps in it. They're not paying for preconception care. They're not paying for postnatal demise, if an infant dies or there's a stillborn. They're not covering the consequences of that, so we are advocating for them that a client will have needs and will suffer, and those things have to be covered. So they're looking for certain things, and once we can agree on what they want and what we want to do for the community, we expect them to give the go-ahead and say, submit your proposal. We give them a kind of ballpark for the proposal and said, well, it's only a ballpark. It could be higher than that based on what we finally work on, but we said to them, we think we need at least $1 million a year for this to go with it, with $1 million in the first year. And they kind of said, okay, you know, let's see a budget and things like that. What I want to impress here is that when we asked them for that from Brooklyn, our managed care plan partner, Health Force, who's the key managed care plan that is interested to work with us, said this should be an upstate, downstate pilot for the state to get the best out of it, so that we're not just working with Brooklyn. And we asked the state, will they be willing to fund a cross-state initiative, so that in Brooklyn we can deal with our community in Lower Hudson Valley, up or wherever, Rochester, they can also qualify for grants. And they didn't say yea or nay. It's something for them to respond to. I think they're waiting to get their hands around exactly how, you know, it looks like we'll do this, and then they'll say, okay, we'll take this bite and then we'll take that bite. But we do have the Monroe Plan for Health in Rochester, who appears ready to jump on board if this approval is given for this project. Now, with regard to the perinatal health information technology, this project requires robust technology. And so we are hoping that the PHIT can be expanded and modified to meet the needs of the Pathways Hub. But we want to start with what we have, because building technology can take you into ad infinity to get it right, and we don't want to have to start over and wait and wait and wait. So the perinatal health information technology and the Pathways Hub, we're hoping to fuse together to build on what we have done already.
Perfect.
Very exciting.
Amazing. All right, so everybody's going to hold their questions. So we're going to Thank you both. Very exciting work. Who's in your seat, so I'm getting it back too. Thank you. Okay, so everybody's going to absorb that, and this is yours too.
Yes, thank you.
And now I'm going to ask Laura to come up. It's actually really perfect segue. So
The
we're
thing
gonna-
about going second is the technology's already set up, so you
Yeah.
don't have to.
Yeah, does everyone need to like stand and
Do you need
shake
to
for a minute?
stretch?
How are we feeling? About how much time do I have?
You're good. You need to read that.
Yeah.
Maybe for some-
Thank you. All right, thank you all for having me. My name is Laura Gustin. I'm the Director of Strategic Initiatives at the United Way of Greater Rochester. And I came to United Way out of about 15 years in the health sector, working at FQHCs and in health planning. Spent a couple of years at our local PPS, designing some of our work around disrupt, and then really felt like there was real need from the community perspective to work with human service organizations and prep them for a future environment. And so I moved to the United Way in that capacity. I'm going to talk to you today about our Monroe County System Integration Project. We'll talk about levels of change. I think it's a level of change a little bit higher than what we just heard about. And we'll talk a little bit about, also before I start, I want it just in terms of scope. So Rochester is Monroe County, the county that Rochester is located in, if you're not familiar with upstate New York. Monroe County has about 750,000 people. The city of Rochester has about 205,000 people. Another thing important to recognize about Rochester as we start this is Rochester has the third highest poverty rate in the country, at the highest rate of childhood poverty, and the highest rate of concentrated poverty. And so you'll see in here as we talk about why this project came into being. On one hand, we had disrupt happening, but on the other hand, we had a huge awakening in our community about the state of poverty and a real need to address poverty. So that as background. This is the system. This is how I always start talking about this project. This is actually the system of health, human services, and education that people who are reliant on public programs need to navigate to get the services that they need. This is actually a true flow chart of the federal spend across health, human services, and education. And I often say, if you look at this picture, think about it expanding again as those dollars flow to the state level and the number of programs are expanded. And then think about it expanding again as those dollars flow locally and you have a philanthropic spend that goes up next to it. And so when we talk about system integration, we're talking about making sense out of this mess that we expect people to navigate in order to produce better outcomes. So in 2015 to 2016, we had IBM come to Rochester, New York, and help us think about how we begin to address poverty. We participated in a Smarter Cities Challenge, and as we engaged in that work, IBM came back and said, You have a lot of programs in Rochester. You are program rich and you are outcomes poor. And these are the reasons. So you have misaligned services and programs, including no real 360-degree view of a person in need, reliance on manual processes, inconsistent eligibility rules. We have reactive transactional service delivery with little focus on proactive or preventive actions. We lack person-centered service delivery and measurement systems. And as a funder, I can take some responsibility for this. Funders have asked people to measure in all kinds of different ways. And so our measurement systems are institution and funder-centric instead of person-centric. And we have an inconsistent approach to data. So as a result, we have all of these outcomes that we're trying to achieve. And as healthcare moves to value-based payment, even outcomes that we're going to be incented to achieve. And yet, as people sort of work towards as we ask people to move towards these outcomes, we find that there's huge rungs on those ladders missing. And those rungs aren't based in, they're not clinical rungs. They're rungs that have to do with food security and housing and transportation, education, health, safe neighborhoods, jobs. If people can't get to a basic level of stability in their life, we can never expect them to achieve those really difficult outcomes the state is asking us to produce. So in 2015, in our community, it was really a moment in time. Like I said, on one hand, there was an article that came out produced by the Rochester Area Community Foundation that really highlighted poverty in our community and really brought to light and created a call to action in our community about needing to manage poverty and to come up with some solutions. And then on the other hand, we had DSRIP happen. And so Rochester Monroe Anti-Poverty Initiative, I don't know if you're familiar with the Empire State Poverty Reduction Initiative. RMAPI, as we call it, existed the year prior, and Empire State Poverty Reduction Initiative came out in order to take what was happening in RMAPI and see if we could expand it statewide. We got $2.7 million to solve poverty in our community, and our DSRIP award was $565 million across our 13-county region to redesign Medicaid. And so we had these two initiatives with some different dollar amounts associated with them, but with some things in common. First, they were both prioritized by New York State. They were both asking for large-scale change across our service providers. They both had a common target population. So we lack person-centered systems, but we have this common target population, and we're being asked to build systems for them. They were both saying, you need to integrate with human services. And they both wanted to leverage technical innovation. And I didn't add it to this deck, but in the deck that I use locally, some other things happening at that time, we had community schools beginning to come up in our community. With community schools, we have 11 failing schools in our city school district right now. The state has said all of them have to become community schools in the next 2 years. They have to do all of these things as well. This is important because, and I will say, I shared with you about the size of Rochester, and I think our approach is in some ways related to that. We had all of these initiatives that were asking us to be innovative in our approach, to use data, to engage CBOs, and we were beginning to go down parallel paths in each of them. And so over time, it became really apparent that in our small city, we're going to develop brand new, even fancier silos. And so we decided we had to do this a different way, particularly because as a person living in poverty who needs to access these different systems, even new fancy systems we are creating, we weren't going to change the person experience if we didn't figure out how to work together. I want to take a minute. Does this move? Usually I'm on the other side. I'm a little discombobulated. Okay. So I want to take a minute and talk about where change happens. So we're really, I think for the past decade, particularly as funders have thought about evidence-based programs and funding evidence-based programs, we spent a lot of time doing change at the person level. This is person level change through evidence-based programs, protocols, or curricula. So there's a lot of funding in that space. We've begun to recognize that we also need change at the service provider level. You all are doing a capacity building project. That's really what we're talking about. So organizational change through infrastructure building, capital improvement, or organizational development. At least in Rochester, our CBOs really need a lot of work in this space. Because as funders, we funded a lot of great programs and haven't paid a lot of attention to operational capacity. Change also happens at the sector level. This is district, right? We're going to redesign the Medicaid delivery system. We've sort of said we need to actually do change at a level even higher than that. We need to begin thinking across sectors to say, how are we going to work not just in a collaborative way, but in an integrated way to produce new solutions that are people-centered. So in 2015, as I said, as all that was going on, we were blessed to have the majority leader of the New York State Senate, Joe Morelli, in our city, and people kept coming to him, maybe complaining about DSRIP or talking about RMAPI and the need for more money, and he said, enough is enough. I'm going to get you all around a single table, because you're all asking me for money to pretty much do the same thing, right? Same technology, same target population, et cetera, and we're going to think about how we do it together. So he formed a system integration team, and Joe's wife is a school teacher in East Arundel, which is a suburb right outside the city of Rochester. And so for the past 2 decades, he's heard so many stories from his wife about students who get lost in her classroom. Students who come to her classroom and end up lost. And so he pretty much said, if you're going to think about transforming human services and health, education has to be part of it. That's a non-negotiable. And so we said, we're going to try to do this. We're going to form something called the System Integration Team. And the role of that System Integration Team is to connect and coordinate institutions and initiatives across health, human services, and education that are engaged in systems change activities. So we're not developing a new initiative. I sort of think of this as like open source data. We're developing common tools that can be used across initiatives engaged in innovation so that we can begin to build person-centered systems over time. So I'll get into our work to date. We've been in process for about a year. I think our first meeting was August 15th of last year. And in the beginning, we sort of knew we wanted to do this, and Joe said we had to do this, and but we didn't know much more than that. And so we started with an environmental scan, which really we did 4 things. Developed a collective vision, did some benchmarking against national work in this space, created a theory of change, and did a stakeholder map. So I'm going to walk through those real quickly. So like I said, the first thing we did was come up with a collective vision, which is the greater Rochester community is working across a diverse network of committed providers to build an interconnected person-centered system of health, human services, and education, leveraged by a unified information platform to improve the health and economic well-being of individuals and families, especially those who are vulnerable or impacted by poverty. As we began to do benchmarking and thinking about what we wanted this system to do, we began to do a lot of research to what it meant to live in poverty, and also what it meant to be self-sufficient and what were the gaps. So in Rochester, for example, in order to be self-sufficient, so to pay for your basic needs, to not have to access that big, huge, chaotic system, you need to make $65,417 a year. And we began to look, if you had a female-headed household with an infant, a preschooler, and a school-aged child, what is the gap? What are the things you have to give up if you make $10 an hour? So for example, we began to recognize you could pay for your housing, your health, and your car, but not food, not things like dish soap, not your taxes, or you could pay for half of childcare and nothing else, or just food and your taxes and nothing else. So really began to recognize what are those hard choices that people are faced with in our community. I will say, from a process standpoint, this has been super helpful in engaging business leaders, for example. You know, not just talking about poverty, but talking about how much it really costs to live in our community. And that the system isn't just accessed by those who are living in poverty, but they're accessed by anyone who makes under $65,000 a year. Those are way different numbers, and they see their children and their brothers and sisters and their nieces and nephews in that picture. And so that's been super helpful. The next thing we did is start a process related to a theory of change. And you're not meant to have to read this, and I can share my deck with you after the fact. Because we did the Smarter Cities Challenge, the IBM report was a real starting point for us to begin thinking about what we needed to do in the community. We recognized early on that we needed to make changes in both technology and service delivery. We took what was in the IBM report and drafted a theory of change. And some of the things on here, so like conduct community engagement, establish secure data hub for storage, engage in capacity building, develop a matrix of services for eligibility and capacity by program. These are some of the actions that we needed to take. And what happened in our room, at this point we had grown from probably 15 providers across health, human services, and education to about 30. People were starting to build interest. And people started to say, I do that, I can own this project, right? Different people in the room. Because when we're talking about the level of data sharing that we're proposing here, there's power in that. And so people kept calling me up, calling my boss up, calling Joe up. They kept having parking lot conversations to say, hey, we do this, let's take this over, let's own this. And so we tested it. We took this line, our line of actions in our theory of change, and we used a software program called Kumu, K-U-M-U, which allowed us to create a systems map. And what we did was interviewed every organization at the table, and we asked them for everything in the action line, what do they do? And also, what other organizations or initiatives are you connected to? And what we found was everyone was doing everything. Like there was no owner of anything. Like a data hub, you'd think a data hub would mean it's a hub. You have one. No, we had 7 data hubs in our community. 7. So everyone thought they owned it because they were doing it. They were all doing it, but no one could own it because that would mean other stakeholders were either going to get up and walk away and do their own thing or be left out. And so this was a really great process for us to understand current state and to do some real level setting and to really prove why the table was necessary. So after we finished our environmental scan, we sort of had an idea that everything was happening everywhere, and we sort of knew we needed to change some service delivery and do some technology. But we really needed to say, okay, that's great, but now what? So our second phase, which was January to March of this year, was really about creating an environmental scan, which included a few things. We had to refine our scope and outcomes. We had to define what our implementation approach was going to be, define our preliminary activities, and then define how we were going to pay for it. Probably the next step, the first thing we did in January was really think about design goals. At this point I probably have 45 leaders, and to give you an idea of who sits in our room, I have my superintendent of schools of the Rochester City School District, I have executives from the 2 health systems, I have executive leadership from many human service organizations across town, School Boards Association, key leaders in each sector, the Monroe County Sheriff, our local insurer, Excellus Blue Cross Blue Shield. So we had a good number of people, probably 45 at this point. I make them do a lot of group work because we have different sectors. We have people from different sectors with the exact same job who have no common language. And so they get in groups of 5, and we spent a lot of time doing group work, and one of our key activities was to create design goals. To say, you want to maybe do this system, you want to change service delivery, you want to build this technology, what are our common goals that we have in order to build this system? So example, they said it needs to be accessible. It needed to hold both users and individuals. It needed to have an accountability or address accountability. It needed to do no harm. Implementation needed to be apolitical. We needed to be innovative, person-centered. It needed to be simple. Once we had some consensus about what our design goals were, we went back into our theory of change and said, for each piece of our theory of change, based on what our design goals are, how do we need to evolve this? So these are example of, this is accessibility, for example. So we said if the integrated, an integrated system is implemented in place to ensure access. So in place, in community. Really began thinking about, if we're talking about access, what does that mean in terms of how we define front doors, for example. We needed to develop accessibility standards as part of the activities we needed to undertake. So we don't say things just to say them. If they come up with things like design goals, then they have to live in our work. This is the final version of our theory of change, and I'll walk through an abbreviated version in a few slides. But it took us a long time to get here. We created our first draft of our theory of change in November. We probably got a final draft in February. And I'm happy to forward that on so you all can see it. So we have this great theory that we all agreed upon. And I go through the theory of change because it's been a great, my philosophy and the way I manage this project is we use a lot of process to create consensus and trust. And so as through the slide deck, I tried to share with you different processes, and certainly the theory of change and the development of that theory of change has been a core component of our process over time. But it was just a theory, so then now what? In March, we said we need to take this theory of change and actually figure out how to turn it into a how. So we had a summit. We brought together 100 subject matter experts. Mostly that was those sitting around the table were asked to nominate subject matters from their staff. And some core areas. So legal, we knew there was some legal work that we'd have to figure out. Communication alignment and engagement, integrated service delivery, technology, change management, and outcomes. Key thing here is how, right? So we said, this is sort of what we're thinking we want to do. How would you do it? So we actually had them draft a work plan. And then we said, what are the barriers to those hows? And then how would you solve those barriers? So we walked away. It was definitely worth, we put it together in like 3 weeks. But it was worth the time and energy to walk away from this day with some real action. An example is on the legal work group, I had 7 lawyers in a room. I had city, county, 2 health systems, our Rio, city school district, BOCES, and one community-based legal entity. And I showed them our theory of change, and I said, we want to do all this data sharing. And they said, absolutely not. That's how they started their day. But we had facilitators in each of the work groups, and by the end of the day, they actually said, this might not be that hard, because we have robust infrastructure already in place. Our district has a lot of data sharing agreements already happening, and we have a really robust RIO. So how can we build upon that? And as part of their action plan, the how, they said, the first thing we have to do is really think about what our minimum data set is. And if we can understand the minimum data that we want to exchange within this data ecosystem, we could do a legal analysis of it. And in some ways, some things we'll find out actually we can do more than we thought we could. In other ways, we might identify really antiquated laws in New York State. But we have, as a community, we have real power all going together to Albany to say, this really antiquated law is prohibiting us from producing outcomes. And I will say since that time, our Rio submitted a grant to NYS and actually got a grant from NYS to support us developing our minimum data set, doing the legal analysis of that, and also working on informed consent, and that work's been underway for about 2 months. So again, this was a year ago, and then this was in March, and then out of the summit really came what our work plan had to be. And we recognized in April that we really had to do 2 parallel processes. First, we had to take on some structural activities. I will say that we did not deal with governance in this project until this summer. So I had 45 executive leaders meeting every other week for 9 months to work on this project, but there was no decision-making process. We were learning together, we were planning together, we were iterating together, but we didn't need to make a decision, and so we kept governance off the table. Now we're at the point where we're getting funding for this project, so governance is necessary. But at this point, we have enough trust in the room where actually people have said, you know what, it's okay if I don't sit at this table and if I'm informed in other ways, because I've earned the trust I've learned to trust the people around me and know how they're gonna make decisions. At the same time, we're working on formalizing our structure, putting our strategic and business plan documents together. We've also said there was real fear for a long time that governance would derail everything. And so we said, no matter what, we're gonna have parallel processes. So as we've been working on governance at the high-level system integration team all summer, we've moved ahead, developing our minimum data set, working on data normalization. I'll go through some of what our activities are, and part of what I've said at staff at least is, if everything falls apart, we will still have produced products and continue to produce products that can be picked up by anyone and the work will go on. So that's really our goal, that we can continue to check the box and create these sort of open source common tools that anyone can use. And if the project falls apart, the tools and the thought and all of those things are still in place. So quickly, this is our theory of change in abbreviated version, but I want to just highlight a few things. First, our ultimate goal is tied directly to our vision to improve the health and economic well-being of individuals and families, especially those impacted by poverty. 2 high-level outcomes: to create an interconnected, person-centered system of service delivery, and to reduce the cost of inaction and efficiency over time. And when we talk about the cost of inaction, we think about it both numerically, financially, and also based on outcomes. So what is the human cost? Below that, lower level outcomes. First, appropriate system utilization by the target population. And we have yet to define appropriate, but we're getting there. Implemented protocols for integrated service delivery. So we talk a lot about technology, and right now we spend a lot of time about technology, but for every 1 hour meeting, when we start with technology, we inevitably end up with workflows. We're really talking about how organizations work together in really different ways. The technology is just the tool. And then coordinated investment in technology, service delivery, and capacity building. Coordinated investment. What does it mean when you have health, human services, and education at the table, and you're asking for coordinated investment? It means some people need to take some of the money that they have and move it into other places. And part of the value of the technology is creating the data to understand where that money should be spent. So the outputs, in order to create our outcomes, are 4 strategies. The first is around user access. User access has 2 core categories. The first is informed consent. And I will say informed consent, both words are action oriented. So what does it mean to have an informed population about what we're trying to do? How do you produce that? And then how do you ensure they consent to have their data shared in the ways that you're suggesting? Second is accessibility. And here we think about accessibility a little bit different. Again, if we're creating person-centered systems, how do we create access based on definitions driven by community? So I come from Steuben County. So if you don't know anything about Monroe County, Steuben County is on the Pennsylvania border. It's about the size of Rhode Island. I think it's the dairy capital of New York State. It's about an hour and a half south of Monroe County. My parents still live there. I live on the east side of Rochester. I grew up in Steuben County. I live on the east side of Rochester. For me, accessibility and mobility goes from Lake Ontario on the east side of Rochester all the way down to Steuben County. I know every back road. You could make me an appointment anywhere from here to there and I would get there. But if I cross the bridge to the west side of Rochester, I do not know how to get off one single exit.
What if you don't drive?
Well, that's exactly, and this is just it's my cultural experience, my patterns of mobility. My definition of access is different from my partner who grew up in the suburb where we live, or someone who lives down in the city, someone who has no car. And so we think about access and we look at a zip code or a geography and use a ratio to define accessibility. And that might be the starting point, but that's only the starting point. Second core strategy is around integration. This is the one that's most interesting to most. This is where we spend a lot of our work right now. Integrated digital tools. So how do we share information across sectors? What information are we going to share? How does the school district get an alert from criminal justice when a student's parent has been arrested the night before? And how do we leverage a data system to do that? How does the hospital system understand that a person is food insecure, and so at discharge, they're providing a food basket to that house to provide food stability for 2 weeks during recovery?
When you talk about accessibility, is it more than just mobility?
Yes.
And then the other thing is in terms of, I don't know if this is a hot spot where you are, but in terms of the burden of police, do you have an immigrant population in Rochester?
Yes, but I would say it's not as much of an issue in Rochester as it is here.
And then my third and last question is, I know there's a school for the deaf in Rochester. Is there more cognizance of people who are deaf and the needs of the deaf because there's a school for the deaf in Rochester?
Not at the project at this point. A lot of those needs are managed very poorly, but also, so that's an example, and this is something I struggle with a lot lately because now we have this project and people raise their hand and say, how do we get involved? I will say a lot of the work we're doing now is more about width and not depth. So yesterday I met with Bavona Child Advocacy Center, who very much is focused on abused children, and they already have a coordinated network, and it's very specific to a very specific target population. Will we get there? Yes. Will we get there tomorrow? Probably not. So we really are at this point more focused on breadth than we are on depth.
Laura, I just want to give you a heads up because we are about 20 to 4 and I want to make sure people have time for questions.
Sorry. Very quickly, strong multi-sector partnerships and then shared accountability. I just want to note, we're beginning to recognize in this work that we are as community responsible for outcomes. So City School District has a terrible graduation rate. That's not just the responsibility of City School District, right? And so creating systems that measure based on shared accountability and then thinking about what are the incentives if we have shared accountability, how do you change incentives to support integration and create value? How do I move money to a housing if housing is what people need to be healthy and graduate? I won't get too in the weeds. I will just say this is sort of what our project is. It includes on the data side, closed loop referral, screening and assessment, though that's begun to evolve, and I'll touch on that in a second, and then a 360-degree view dashboard. The real thinking about an analytic engine that can be used and owned by community. And then evolved practice, particularly around front doors. So where do people really want to, what are front doors truly needed by people? Like for me, my PCP is not my front door. Like I have to pay to go there. Like that's not where I'm going for services first. Warm handoffs and navigation. So if we build up front doors and give them the tools that they need to be successful, how is part of that new protocols for handoffs and navigation. And care coordination and care management, we did an assessment and found the average person in our community has 6 care managers. Mm-hmm. And so how do we begin to manage that over time in hopes of person-centered service delivery? This is a quick example. This is our 360-degree view dashboard. You'll see there's different areas here, health, food security, housing, childhood education, etc. How we talked about and decided to share widely across community is using a self-sufficiency matrix. And so for each of these areas, people will be assessed commonly and be given and be rated based on where they are from crisis to stable to thriving in any given area. So I'm not sharing that your child broke his femur 4 years ago, but I might be sharing that you're in food crisis or transportation crisis. We also have a 0 to 8 early childhood initiative called All Kids Thrive, and they've created a childhood dashboard related to being developmentally on track. Because we know those screenings, a kid can be developmentally on track screened, not developmentally on track in the education system, not developmentally on track in the pediatrician's office. There's 2 parallel work plans that a parent is asked to produce, and we're off. So again, self-sufficiency tool, we've evolved what's in this and continue to evolve, but it is a core to the data model that we're using. And so for each of these, there's actually an equation in the background that, based on different pieces of data that live across our community, can help place a person in any given box and change that placement over time. And one of the things we're doing in support of this is saying, for each of these, so this is housing crisis. I also staff the service provision working group over MAPI, and what we're doing is, we're also mapping, which is so interesting that you have pathways. So we're mapping what our existing service delivery system looks like to transition a person up a level. So this is crisis housing only. So this is our service delivery system and what happens when a person enters a front door and where they go to the point where they get a bed. There's 11 assessments in this map just for housing crisis. And if you show up too late at the front door at DSS, you can actually go through this whole process and not get a bed. The other thing we've really found, I think this is my last slide. One thing we found in this process is our system is built to support people who are crisis or vulnerable and not to get people to stability. Mm-hmm. And in Rochester, people cycle in and out of poverty every 5 years, and now we're beginning to understand why. Because we never help them get stable. We spend all of our time solving crises. What's underway? System integration teams doing desist structure. We have our legal work group looking at data sharing. Data normalization is looking at data system business requirements and our minimum data set. And our outcome working group is working on shared accountability and how we measure return on investment. Key learnings, create momentum. Like I said, we met every other week for 9 months. And everyone showed up and continue to show up. But I think they're afraid they would miss something in the beginning, and now it's habit and we have real momentum. And people know that we're gonna keep moving the work forward, and so they show up. Create culture, I was supposed to put a bullet under here, but one of the things we did recently was we decided, what are the things that you are willing to be accountable for, that you also want others around you to be accountable for? And we co-created some culture that we walk through every meeting. Hold off on governance if you can. Governance is hard, and we're like 5 meetings in, and if we took 5 meetings early on to do governance, I think things would have probably fallen apart. There's value in community-based development. I've done a lot of conferences and seen a lot of tools developed out of health systems to do shared data, and the most successful ones I've seen were actually built by community, not by health systems. No offense if there's health systems. CBOs have a different starting line. Like, you can't just expect to implement a huge data sharing model and think that CBOs can just step up to the table. Even my table where I ask people to convene, people don't necessarily have the resources to provide the level of staff and input I need from them because they're running on next to nothing. So we're beginning to think about how do we begin to fund CBOs to just participate differently than health or education. And trust, like trust is so important, and we work on building trust every single meeting. It could all fall apart because of trust. I don't know, that's it. Sorry.
Thank you. So, we have some time to take some questions for our friends from Brooklyn and our friends from Rochester.